Hello, everyone. For this video, I'm going to talk about what. Hello, everyone. My name is John Bachman. Today, I'm going to be talking about what I appreciated from Deanna Thompson's book, Hoping for More, Having Cancer, Talking Faith, and Accepting Grace. I will also explain how I would apply the book to my clinical case study and then how I would apply the same insights in my personal life. Um, what I appreciated most about Thompson's book was how honest she was about suffering. She does not describe illness in a way that feels fake or overly positive. She does not act like faith makes fear, pain, or grief disappear. Instead, she writes about cancer as something that disrupted almost every part of her life. I appreciated that most because nursing often places us together, close to people during some of the hardest moments of their lives. Patients may be in pain, afraid, grieving, or facing a future they did not expect. Families may be trying to make decisions while also trying to process what is happening emotionally. In those moments, nurses may not have the perfect words. Thompson's book reminded me that care is not always about having the right answers. Sometimes care is about presence, honesty, and being willing to stay with people in their plan. What I took away from the book is one passage that stood out to me was when Thompson writes, "This story began in fracture and ends in hope, but the path from fracture to hope is not a linear one." I think this is one of the most important ideas in the book. Hope is not always a straight path. A person can have faith and still be afraid. A person can be grateful and still grieve. A patient can have moments of peace and still have moments of anger or sadness. Thompson does not separate hope from suffering. Instead, she shows that hope can exist inside suffering. For my clinical case overview, uh, that insight connects directly to the clinical experience I described in part two. In that case, I cared for an older adult patient who was declining after complications related to heart failure and respiratory problems. The patient had been hospitalized for several weeks and was becoming weaker and less responsive. The care team had started discussing comfort focused care with the family. The patient was physically suffering and needed comfort measures, oxygen support, repositioning, medication, and close monitoring. The family was also suffering emotionally. Some family members seemed to understand that the patient was nearing the end of life, while others appeared to still hope the patient might recover. The groups of people involved included the patient, the spouse, bedside nurses, nursing assistants, respiratory therapy, providers, and palliative care team. This is important because suffering was not only happening to the patient, the family was grieving, the nurses were trying to provide comfort and communication, and the interdisciplinary team was working together to support a difficult transition. Compassionate care is this type of situation, includes everyone affected by the patient's suffering. Thompson's book helps me think about how I would offer compassion, dignity, and care in this situation. First, I would apply her apply her honesty about suffering. I would not try to cover the pain of the situation with empty reassurance. For example, I would avoid saying something like everything will be okay because that may not be true in the way that the family wants it to be true. Instead, I would use honest and compassionate communication. I might say, I can see how much you love them. We're going to continue focusing on comfort and making sure they're not suffering. That kind of response is truthful but still caring. Second, I would apply Thompson's idea that hope is not always simple or linear. In this case, uh, hope may have changed over time. Earlier in the hospitalization, the family may have hoped for recovery. As the patient declined, hope may have shifted toward comfort, peace, dignity, or meaningful time together. As a nurse, I can support the kind of hope without giving false hope. I can help the family understand the comfort focused care does not mean the team is giving up on the patient. It means the focus for of care has changed to relieving suffering and honoring the person. I would also protect the patient's dignity. Serious illness can make a person feel powerless. Even if a patient is less responsive, I would still speak to them respectfully before providing care. I would explain what I am doing, keep the patient covered as much as possible, close the curtain, maintain a calm tone, and be gentle during repositioning, or hygiene care. These may seem like small things, but they communicate that the patient is still a person deserving respect. This connects with our course materials on palliative and end of life nursing. LNEC focuses on improving palliative care and includes topics such as nursing care at the end of life, pain management, symptom management, ethical issues, cultural and spiritual considerations, communication, grief, bereavement, and final hours of days. In this clinical case, those areas are directly relevant. The patient needed symptom management and comfort. The family needed communication, emotional support, and help understanding what was happening. Another quote from Thompson that connects to this when she writes that the church is really being the church when it is present with those who suffer. Even though she is talking about the church, I think the same idea can apply to nursing. Nursing is really nursing when we are present with those who suffer. That presence can look like giving medication, holding a hand, answering a question honestly, lowering the lights, protecting privacy, or simply staying calm in a painful moment. In my personal life, hoping for more challenged me to think about how I respond when people I love are hurting. I have realized that I often want to fix things quickly. If someone is upset, I may want to offer advice or solve the problem right away. But Thompson's book reminded me that not every painful situation can be fixed. Sometimes people need someone to listen before they need advice. This applies to my marriage. There have been times when I tried to do something for my wife to make her happy or make her feel loved, but I did it in my own love language instead of hers. When she did not respond with the excitement or appreciation I expected, I felt frustrated or underappreciated. Looking back, I can see that I was focused too much on my effort and not enough on what she actually needed. Thompson's book helped me understand that real care requires listening and humility. It is not just about doing something nice, it's about knowing the person well enough to care for them in a way that actually reaches them. I also want to apply this book by becoming more comfortable with silence and discomfort. If someone I care about is grieving or struggling, I do not need to rush them into feeling better. I can be present, I can listen, I can ask what they need, I can stay close even when I don't have the perfect words. And for my takeaways, overall, what I appreciated most about Hoping for More was that Thompson made hope feel honest. Hope is not pretending that suffering does not hurt. Hope is not forcing people to be positive. Hope is trusting the grace, compassion, and love still matter even when life is painful and uncertain. As a future nurse, I want to carry that lesson into my clinical care by offering compassion, dignity, honesty, and presence. In my personal life, I want to become a better listener, a more patient husband, and someone who can show up for others needing without needing to fix everything right away. And then these are my references. Thank you for listening.